Welcome back to Pill Talk. In this video, we will be talking about arrhythmias. Arrhythmias, a term that means an irregular or abnormal heart rhythm. Under normal conditions, the heart beats at a steady pace thanks to electrical impulses that guide it. However, when these impulses are disrupted, the heart rhythm can change. So, arrhythmias can cause the heart to beat too fast, too slow, or in an unsteady pattern. So these changes in heart rate happen because of problems in the electrical signals controlling the heart's function. Understanding how arrhythmias work is important because they can impact how efficiently your heart pumps blood, affecting overall health. Before jumping on towards the drugs that are used to treat arrhythmias, let's discuss about the background of arrhythmias. So the heart is a complex yet essential organ made up of 4 chambers, the right and left atria and the right and left ventricles, as you can see in that image. So these chambers work together to keep blood flowing through your body. When the ventricles contract, they pump blood out of the heart, ensuring that oxygen and nutrients are reach the rest of the body. So this efficient movement of blood relies on the heart's electrical conduction system. It creates and sends electrical signals that prompt the atria and ventricles to contract in a precise sequence. So without the systems, the heart will not be able to coordinate its beat or pump blood as effectively. So at the core of heart's rhythm is the SA node, which acts as the heart's natural pacemaker. It initiates the electrical impulses that triggers the contraction of the atrial myocardium. So when this impulse is generated, it depolarizes the atria, creating the P wave that you can observe on an ECG reading. So after the atria contract, the signal reaches the AV node. Another critical structure is called atrioventricular node, and short form is AV node. So the AV node slows down the electrical signal slightly to ensure that the ventricles have enough time to fill with blood before contracting. So this delay is important for keeping the heart pump efficiently. So once the signal passes through the AV node, it moves quickly through the bundle of His, as you can see through this image, a group of specialized conducting fibers that is called bundle of His. So these fibers rapidly transmit the impulse, ensuring that the ventricles contract powerfully and in synchronization. So the bundle of His play a key role in generating the rapid action potential necessary for effective ventricular contraction. So this is the image of ECG. Let's understand this. So the PR interval is an important part of the heart's electrical cycle. It represents the time from the end of the P wave to the start of the QRS complex on an ECG. So this is when both the AV node and the bundle of His are activated, playing their roles in regulating the heartbeat. When there are issues with how the AV node or bundle of His conduct electrical signals, it can lead to heart blocks. So these heart blocks are categorized into first, second, and third degrees, depending on the severity of the conduction delay. These irregularities are identifiable on an ECG, helping doctors understand the level of disruption in the heart rhythm and manage it accordingly. So back to the first diagram. Once the electrical impulse passes through the bundle of His, it is directed into the right and left bundle branches. Now you have to understand the bundle of His is also divided into 2 portions, right and left bundle branches. These branches are responsible for generating a rapid or fast action potential. The left bundle branch further separates into the anterior and posterior fascicles, each of which play a role in efficiently conducting the impulse to the ventricles. From here, the signal moves through the bundle of branches into the Purkinje fibers. Purkinje fibers is basically a network of specialized conducting fibers. So this network ensures that both the left and right ventricles are rapidly activated and depolarized, leading to the contraction of the ventricular myocardium. So this process where the ventricles contract is reflected in the QRS complex on an ECG, showing how the heart is pumping blood efficiently. So back to the ECG diagram. When the ventricles contract, they pump blood out of the heart into the aorta and pulmonary circulation, ensuring that oxygenated blood reaches the body and the deoxygenated blood flows to the lung, as we already know that. So this phase of ventricular contraction is captured by the QRS complex on an ECG, as you can see that. After the contraction comes the relaxation phase, which is represented by the T wave. So this part of the ECG marks ventricular repolarization. Basically, T wave shows ventricular repolarization. So that is the moment when the ventricle relaxes and resets. It prepares itself for the next heartbeat. It is important to note that atrial repolarization happens around the same time, but it is hidden within that dominant QRS complex, making it less visible on the ECG. Let's move on toward the chapter number 19 of Lippincott, Antiarrhythmics. I will provide a quick short summary of each important topic I consider, and I will also put the reference of that book in the caption below. So the overview says of this chapter is arrhythmias occurs due to the issues in the heart's electrical system leading to irregular heartbeats, as we already know. Unlike skeletal muscles which contracts when stimulated externally, the heart muscle contains special cells that can generate their own electrical signals automatically. So these pacemaker cells play a key role in initiating the heart's rhythm. In particular, these cells control spontaneous depolarization, which is a process where ions like sodium and calcium move in and out of the heart cells, causing the heart to contract. So the fastest electrical activity starts in the SA node, also known as sinoatrial node, and moves through the AV node and then the bundle of His and then the Purkinje fibers, guiding the heart to beat rhythmically, as we already discussed in the previous slides. So when any part of this pathway is disrupted, it can lead to arrhythmias. Different types of drugs known as antiarrhythmics are used to treat these rhythm disturbances by targeting various parts of the heart electrical system. So introduction to the arrhythmias portion says that arrhythmias are linked to problem in the formation and conduction of impulses within the heart. They are not a single disorder but a group of related conditions with various symptoms. In order to understand how to treat them, it is essential to categorize arrhythmias based on where the problem occurs, whether it is in atria, AV node, or ventricles. So antiarrhythmic drugs are classified based on their effect on the heart's ion channel or receptors. For example, class 1 drugs are sodium channel blockers, which slow down the conduction of electrical impulses in the heart. Class 2 drugs are beta blockers, which reduce heart rate and the force of contraction. Class 3 drugs are potassium channel blockers, which prolong the depolarization phase and helps manage irregular heartbeats. And class 4 drugs are calcium channel blockers, which slow down the heart rate by blocking calcium entry into the cell. Other antiarrhythmic drugs include adenosine, magnesium sulfate, and ranolazine, which are used in specific cases to restore a normal heart rhythm. So let's discuss some causes of arrhythmias. So arrhythmias can arise from two primary issues. Number one is abnormal impulse generation, also known as abnormal automaticity. And number two is the problem with impulse conduction within the heart. So let's discuss number one, abnormal automaticity. So normally the sinoatrial node is the primary pacemaker of the heart. It has the fastest discharge rate compared to the other pacemaker cells and set the pace for heart contractions. However, in some cases, other areas in the heart can develop enhanced automaticity, meaning they start generating electrical impulses on their own, which can lead to arrhythmias. So when abnormal automaticity occurs, it may produce competing signals that disrupt the normal heart rhythm. So antiarrhythmic drugs help manage this by blocking either sodium or calcium channels in the heart cells. So by reducing the flow of these ions and increasing the ratio of potassium inside the cells, these drugs reduce the excitability of the heart muscles. It will prevent spontaneous discharges of the electrical signals. So this mechanism is especially useful in cells that have ectopic pacemaker activity, meaning they are generating impulses outside the SA node. And the number two cause is abnormalities in impulse conduction. Another major cause of arrhythmias is related to abnormalities in impulse conduction. Normally, electrical impulses travel through pathways in the heart that spread out and activate the entire surface of the ventricles that would ensure coordinated contractions. However, when there is a disruption in these pathways, such as unidirectional block caused by myocardial injury or a prolonged refractory period, the conduction can become abnormal. So they can lead to a phenomena called re-entry, which is one of the most common causes of arrhythmias. Re-entry occurs when the electrical impulses circle back through the heart, reactivating areas of the cardiac muscles that have already been activated, causing premature or extra heartbeats. So antiarrhythmic drugs help prevent re-entry by either slowing down the conduction of electrical signals as seen with class 1 drugs or by increasing the refractory period as seen with class 3 drugs. So this process converts a unidirectional block into a bidirectional block, preventing the circular re-excitation of the heart and stabilizing the rhythm. So the main goal of anti-arrhythmic drug therapy is to restore a normal heart rhythm and conduction and to prevent arrhythmias or to reduce the symptoms they cause. In cases where restoring normal sinus rhythm is not possible, these drugs help manage more serious or life-threatening arrhythmias. Anti-arrhythmic drugs work in three key ways. We have to memorize this. Number one is decreasing or increasing conduction velocity. This refers to how fast the electrical signals move through the heart, which can help prevent irregular rhythms. Number 2 is altering the excitability of cardiac cells. So these drugs change how easily heart cells are activated, typically by extending the refractory period, the time during which the cells cannot be re-excited. This prevents premature heartbeats. Number 3 is suppressing abnormal automaticity. By preventing ectopic pacemaker cells from firing outside of the normal rhythm, these drugs help maintain a steady heart rate. However, while these drugs can be highly effective, they come with limitations. Many antiarrhythmic drugs have a narrow therapeutic window, meaning that the difference between an effective dose and a toxic dose is small. This makes dosing crucial because if the dosage is too low, the treatment may be ineffective. But if it is too high, the drug can actually cause dangerous pro-arrhythmic effects, meaning it may trigger arrhythmias instead of preventing them. So these paragraphs discuss factors affecting anti-arrhythmic drugs effect. Several factors can influence how anti-arrhythmic drugs work. These factors include race, gender, genetics, disease state, drug interactions, and even neurohormonal changes. So one key example is the inhibition of potassium channel. So by blocking these channel widens the heart action potential, leading to the prolongation of the QT interval on an ECG. While QT prolongation might seem harmless at first, if it becomes excessive, it can significantly increase the risk of life-threatening arrhythmias such as Torsades de Pointes, a type of ventricular tachyarrhythmia. This condition can cause the heart to beat irregularly and at a dangerously high rates. So the most common cause of QT prolongation is drug-induced, but other factors like ischemia, hypokalemia, or genetic abnormalities may also contribute. Many other medications such as certain antibiotics like macrolides and antipsychotics are also known to prolong the QT intervals. So caution must be taken when using them alongside anti-arrhythmic drugs. Combining drugs that affect the QT interval can be particularly risky, so it's essential to monitor these interactions carefully. So the second paragraph discusses classification of anti-arrhythmic drugs. Anti-arrhythmic drugs are classified according to Vaughan-Williams classification system, which groups them based on their predominant effects on the heart's action potential. However, this system has its limitations. Many anti-arrhythmic drugs can have multiple electrophysiological effects and may fit into more than one class. For instance, factors such as the route of administration, plasma levels, and how the body metabolizes the drug can lead to different effects that don't fit neatly into one category. Some drugs like propafenone, quinidine, and amiodarone are prodrugs, meaning they are metabolized into active forms after administration. These complexities highlight the challenges in classifying antiarrhythmics, but understanding their mechanism is a key to effective treatment. So the reference of this table is also from Lippincott. So it shows classification of antiarrhythmic drugs. So antiarrhythmic drugs are categorized based on their primary mechanism of action on the heart's electrical activity. So here's a breakdown of each class. Number 1 is class 1A, sodium channel blockers that slow phase 0 depolarization in ventricular muscles fiber. By doing so, they reduce the excitability of the heart, preventing rapid or premature heartbeats. And the other one is class 1B, sodium channel blockers that shorten phase 3 repolarization in ventricular muscles fiber. So these drugs help restore the heart to a normal rhythm more quickly after depolarization. Next is class 1C, sodium channel blockers that markedly slow phase 0 depolarization. So these drugs are more potent than IA and IB and are often used in cases of severe arrhythmias. Second one is class 2, beta adrenergic blockers that inhibit phase 4 depolarization in both the SA and AV nodes. By reducing the heart response to adrenaline, these drugs lower heart rate and are effective for controlling arrhythmias triggered by stress or physical exertion. Next is class 3, potassium channel blockers that prolong phase 3 repolarization in ventricular muscle fibers. So these drugs extend the duration of action potential, preventing premature contractions and helping to stabilize the heart rhythm. Last one is class 4, calcium channel blockers that inhibit the action potential in the SA and AV nodes. So these are often used to slow down the heart rate and treat arrhythmias that originate in the upper chambers of the heart. Now we will discuss sequentially the classes of these drugs. Number 1 is class 1 antiarrhythmic drugs. Class 1 antiarrhythmic drugs work by blocking voltage-sensitive sodium channels. So these drugs bind more readily to sodium channels that are either open or inactivated rather than those that are fully depolarized. So this makes them more effective in tissues that are frequently depolarizing, such as in the case of arrhythmias where the heart is beating rapidly. This feature is known as use dependence or state dependence, meaning the drugs are more effective in cells that are being excessively activated. Essentially, these drugs help prevent cells that are firing at abnormally high rates from continuing to disrupt the heart rhythms without interfering with normal heartbeats. However, the use of sodium channel blockers has declined due to their potential pro-arrhythmic effects, especially in patients with reduced left ventricular function or those with atherosclerotic heart disease. This risk has made them less favored in some clinical settings. Class 1 drugs are further divided into 3 subgroups based on how they affect the duration of the cardiac action potential, as we already have discussed. Class 1A, intermediate blockers of the sodium channel. Class 1B, fast blockers of the sodium channel. Class 1C, slow blockers of the sodium channel. So first of all is Class 1A antiarrhythmic drugs, quinidine, procainamide and disopyramide. Class 1A antiarrhythmic drugs are sodium channel blockers that slow down the depolarization phase of the heart's action potential, helping to manage arrhythmias by preventing the heart from beating too quickly or irregularly. Let's discuss in the number 1, quinidine. Quinidine is the prototype drug in the class 1A category. It works by binding to open and inactivated sodium channels, preventing the influx of sodium ions during phase 0 of the action potential. So this slows the rapid depolarization of the heart's action potential. Quinidine also decreases the slope of phase 4 spontaneous depolarization, inhibit potassium channels and blocks calcium channels. These combined actions slow down conduction velocity and increase the heart's refractory period, meaning the heart cells take longer to recover and fire again. Quinidine also has mild alpha-adrenergic blocking and anticholinergic effects, which can lead to additional impacts on heart rate and blood pressure. However, because quinidine has class 3 properties which prolong the action potential, it carries a risk of precipitating other arrhythmias such as ventricular fibrillation, especially when combined with other drugs. Second, procainamide and disopyramide are similar in action to quinidine. They also block sodium channel, they also slow conduction velocity, and they also increase refractory period. However, procainamide has less anticholinergic activity rather than quinidine, which may be a safer option for some patients. Disopyramide, on the other hand, has stronger anticholinergic effects, which can lead to other side effects like dry mouth, constipation, and urinary retention. So these drugs are powerful tools in managing certain types of arrhythmias, but because of their potential side effects and pro-arrhythmic risk, they must be used with caution, particularly in patients with underlying heart conditions. So now let's discuss adverse effect of class 1A antiarrhythmic drugs. While class 1A drugs are effective in treating arrhythmias like atrial fibrillation, they also come with significant risks. Due to their pro-arrhythmic effects, which mean they can sometimes cause or worsen arrhythmias and the potential to worsen heart failure symptoms, these drugs are not recommended for use in patients with atherosclerotic heart disease or systolic heart failure. For example, quinidine. When we give large doses of quinidine, they can induce a condition called synchronism, which is characterized by symptoms such as blurred vision, tinnitus, that is also known as ringing in the ears, headaches, disorientation, and even psychosis in severe cases. Quinidine is also known for its significant drug interaction as it inhibits both CYP2D6 and P-glycoprotein enzymes involved in metabolizing many medications. And number 2, procainamide. When administered intravenously, procainamide can cause hypertension, and it may also trigger drug-induced lupus erythematosus, which is an autoimmune condition where the body mistakenly attacks its own tissue. And disopyramide carries the most anticholinergic side effects among class 1A drug. These effects include dry mouth, urinary retention, blurred vision, and constipation. These symptoms arise because anticholinergic drugs block acetylcholine, a neurotransmitter that plays a role in regulating involuntary bodily function. So, due to these potential risks, both quinidine and disopyramide should be used cautiously in combination with strong inhibitors of cytochrome 3A4, an enzyme critical for drug metabolism, as this may increase the toxicity of these medications. Now let's discuss class 1B antiarrhythmic drugs, lidocaine and mexiletine. So these drugs work by rapidly associating with and disassociating from sodium channels. So these drugs are most effective when cardiac cells are in a depolarized state or firing rapidly. They will make them particularly useful in treating ventricular arrhythmias. If we talk about mechanism of action, both lidocaine and mexiletine block sodium channels similar to other class 1 drugs. However, they have an additional effect. They shorten phase 3 repolarization of the cardiac action potential, which decreases the overall duration of the action potential. So this means the heart cells resets and prepare for the next heartbeat more quickly. It will help to control arrhythmias that originate in the ventricles. So a key point to note that is neither lidocaine nor mexiletine has negative inotropic effects. Inotropes are agents that affect the strength of the heart contraction. Since these drugs don't weaken the heart's contraction, they are safer in patients with heart failure or weakened heart muscles. Now let's discuss class 1C antiarrhythmic drugs, flecainide and propafenone. So these drugs are unique because they slow dissociate from sodium channels even when the heart is beating at a normal rate. Due to their potential to negatively affect heart muscles and cause pro-arrhythmic effects, these drugs are generally avoided in patients with structural heart disease such as left ventricular hypertrophy, heart failure, or arteriosclerosis. So if we talk about mechanism of action, flecainide primarily works by suppressing phase 0 upstruct in Purkinje fibers and myocardial cells, which are responsible for electrical conduction in the heart. So this suppression results in a significant slowing of conduction through all cardiac tissues. However, unlike other antiarrhythmics, flecainide has a relatively minor effect on the duration of the action potential and the refractory period. Flecainide reduces automaticity by increasing the threshold potential, which an action potential is, rather than altering phase for depolarization. Additionally, it blocks potassium channels, which leads to a slight prolongation of the action potential. Propafenone is similar to flecainide in that it slows conduction across all heart tissues. However, it doesn't block potassium channel, which sets propafenone apart is its weak beta blocking properties, which further influence the heart rate and rhythm by reducing the effects of adrenaline on the heart. Let's discuss class 2 antiarrhythmic drugs. Class 2 agents, commonly known as beta adrenergic antagonists or beta blockers. They play an important role in managing cardiac arrhythmias. So these drugs work by blocking beta adrenergic receptors, which reduce the influence of adrenaline on the heart. By doing so, they decrease phase 4 depolarization, they prolong AV conduction, they decrease heart rate and the force of contraction. So class 2 beta blockers are particularly useful in treating tachyarrhythmias, that is also known as fast heart rate, caused by increased sympathetic activity such as during stress or exercise. So they are also effective in managing atrial flutter and atrial fibrillation, as well as for AV nodal reentrant tachycardia. Additionally, beta blockers play a critical role in preventing life-threatening ventricular arrhythmias that can occur after a heart attack. Commonly used beta blockers are metoprolol and esmolol. So metoprolol is one of the most widely used beta blockers for treating cardiac arrhythmias. Compared to non-selective beta blockers like propranolol, metoprolol has the advantage of lowering the risk of bronchospasm. It is extensively metabolized by cytochrome 2d6 and penetrates the central nervous system to a moderate extent. Esmolol is a short-acting and fast-acting beta blocker that is commonly used in emergency situations or during surgery to manage acute arrhythmias. It is administered intravenously and rapidly metabolized by esterases in red blood cells, meaning that it has minimal pharmacokinetic interactions with other drugs. Common adverse effects of these drugs are they can cause side effects such as bradycardia, hypotension, and fatigue due to their effect on the heart and vascular systems. So the next is class 3 antiarrhythmic agents. Class 3 antiarrhythmic agents work by blocking potassium channels, which affects the repolarization phase of the cardiac action potential. During repolarization, potassium ions normally exit the cardiac cells, helping to reset the cell for the next beat. So by blocking these potassium channels, class 3 agents reduce the outward flow of potassium, thereby prolonging the duration of the action potential. So what makes class 3 drugs unique is that they prolong the refractory period without affecting phase 0 depolarization or the resting membrane potential. So this increase in refractoriness helps stabilize the heart rhythm and prevent early reactivation of the cardiac cells, which can cause arrhythmias. So it is important to note that all class 3 drugs carry a risk of inducing arrhythmias themselves. This means that while they can be effective in treating certain arrhythmias, their use requires careful monitoring. I'm going to discuss 2 examples of easy case scenario-based questions that could be used for understanding arrhythmias and antiarrhythmic drugs. Number 1 case scenario is a 55-year-old patient with a history of hypertension and anxiety visits the clinic. complaining of a fast and irregular heartbeat. The doctor diagnoses the patient with atrial fibrillation. So the patient is prescribed a beta blocker, which is metoprolol. So the question is, why was metoprolol chosen as the treatment for this patient atrial fibrillation, and how does it help manage the condition? So the answer is metoprolol, a class 2 antiarrhythmic drug, is a beta blocker that works by decreasing heart rate and suppressing excessive sympathetic stimulation, which can cause irregular heartbeats in atrial fibrillation. It slows conduction through the AV node, helping to control the rapid heartbeat and stabilize the rhythm. Case scenario number 2 says that a 70-year-old patient with a history of myocardial infarction is experiencing recurrent episodes of ventricular tachycardia. The cardiologist prescribed amiodarone, a class 3 antiarrhythmic drug. Question is, what is the mechanism of action of amiodarone and why it is used to treat ventricular tachycardia in this patient? So amiodarone is a class 3 antiarrhythmic drug that works by blocking potassium channels, which prolongs the refractory period and the duration of the action potential in cardiac cells. This helps prevent the reactivation of ventricular cells that can lead to rapid and irregular heartbeats, making it effective for managing ventricular tachycardia, especially after a heart attack. So these questions provide simple real-life scenarios and help assess understanding of how specific drugs are used to manage different types of arrhythmias. With this, thank you for watching. I hope this video gave you a better understanding of arrhythmias and the various drugs used to manage them. If you found this content helpful, make sure to subscribe and leave your thoughts or questions in the comments below. Stay tuned for the more insights in our next video. Stay healthy and stay informed.